Welcome to Eggs and Issues, a monthly business forum presented by the Portland Community Chamber of Commerce, bringing timely economic discussion to the region for nearly 40 years. Thank you to our sponsors and partners. Presenting sponsors: Central Maine Power, Maine Health, MEMIC, and Maine Community Bank. Cooperating sponsors: Martins Point Healthcare and NBT Bank. Reception sponsors: Clark Insurance, KeyBank, and Pretty Flaherty. Community Corner sponsor: Goral Palmer. Tomorrow's Leaders and Entrepreneurs sponsors: AAA Northern New England and Mascoma Bank. Parking sponsor: M-People Credit Union. Photography sponsor: Wooler and Company. Media partners: WGAN, Maine Trust for Local News, WMTW, Maine's CW, and Wind Media Company. Business news sponsor: Maine Biz. Venue partner: the University of Southern Maine. And thank you to our special community partners: Anthem Blue Cross Blue Shield, Kennebec Savings Bank, MEMIC, Spectrum Healthcare Partners, Southern Maine Community College, and the University of Southern Maine. And now, please welcome Portland Community Chamber President Rob Atkinson.
Good morning. Good morning. Thank you all for coming. I know we're all still rolling in, so welcome. What a great crowd. We're so happy you could join us for this morning's first session of our spring semester of Eggs and Issues, Maine in Focus, although it doesn't feel like spring. My name is Rob Atkinson, and I'm the Director of Marketing and Public Relations at MEMIC, and I'm honored to serve as the volunteer president of the Portland Community Chamber of Commerce. And today, as I said, we kick off our spring semester of Eggs and Issues, Maine in Focus, and our program today, Working Together, the Status of Healthcare in Southern Maine, will spotlight the role two key institutions play in supporting Maine's broader healthcare delivery system and rebuilding the workforce pipeline. And Quincy, I just want to say thank you for helping me not name this, because I would have gone with some 80s band like Prescription for Disaster or something like that. So well done. Appreciate that. And I also want to thank all of our sponsors of Eggs and Issues, both new and returning this year, to make this event possible for the entire season. Really, without our sponsors' support of Eggs and Issues, the Chamber could not deliver the high-quality speakers, events, panels, and presentations you've come to expect. So thank you very much. I'd also like to extend a very sincere thank you to our special community partners. These businesses and organizations support not just Eggs and Issues, but all of the 70-plus events the Portland Regional Chamber of Commerce produces throughout the year. So please, a round of applause for our generous sponsors and partners. We'd also like to recognize the following businesses who are new members of the Chamber. So exciting. We're grateful to those who have joined since our last Eggs and Issues, adding fresh energy, ideas, and leadership to our network. Please join us and welcome them to the Chamber. What a great list. And if, by the way, if your organization is ready to grow, connect, and make an impact, now is the perfect time to join. Reach out to our new membership manager, Prescott Doyle, to learn more about becoming part of our thriving Chamber community. We're also excited to share that our Chamber staff is now fully here, all staffed, and we're so excited that they can be here today. And if you're in the audience, can you please stand so you can be recognized? They're in the back. Thank you so much. Also, a quick reminder, complimentary parking is available for all Eggs and Issues. Just validate with promo code EGGS2526 and ask for help from a Chamber staff member if you need the help. This month's community partner is Partners for World Health. Partners for World Health envisions a world where all people have access to vital medical equipment and supplies to lead healthy lives on a healthy planet. Through partnerships in hospitals across New England, they collect and repurpose surplus medical equipment and supplies for use in developing countries around the world and here at home in Maine. Each year, hundreds of volunteers in Maine sort, pack, and process medical items at Partners for World Health for redeployment through their global partners. If representatives of Partners for World Health would please stand, and you could be, are you here? Well, please make sure you connect with them on the way out. They're probably outside still. Our Tomorrow's Leaders and Entrepreneurs programs give local students free access to Eggs and Issues. So for all the students in the room today, thank you too for joining us. We appreciate it. Okay, now it's time to dive into today's conversation about healthcare in Southern Maine, and it's a good one. Our panelists are Britt Cruz, President, Maine Health Southern Region, Chuck Morris, Chief Medical Officer, Maine Health Southern Region, John Southall, Southern Physician Executive, Northern Light Mercy, and Marie Vinos, SVP and Regional President, Northern Light Health. And moderating today's discussion is Quincy Hensel, President and CEO of the Portland Regional Chamber of Commerce. Let's all welcome them to the stage.
Good morning. What a great crowd. Thank you all for coming. I think this is a huge testament to how important this topic is for our community, so we appreciate you being here. And if we're going to talk about healthcare in Southern Maine, I think we have the panel to do just that. So I want to thank all of you too for taking time out of your incredibly busy schedules. I'm sure your days start much earlier than this, most days, so we might be giving you a break and starting a little later, but we have a lot to cover. We started early today because we have so much to cover. I'm going to try to talk very little and just lob questions to my panelists. And then as always, we will leave time at the end for Q&A from the audience. So I want to just kind of like set the stage as to like where we are with healthcare and talk about the demographics that we have in Maine. I think we all know Maine is the oldest state. We are the most rural state. We have a very large geography, and we actually have a very high burden of chronic disease within our communities. So I'm going to pass this to Britt and to Marie to talk, just give us a high-level overview of how your healthcare system supports our community, and also talk about how these demographics are impacting our ability to provide the care that we need. And Britt, I'll start with you.
Okay, thank you. And again, thank you all for being here. Very exciting and great opportunity to talk a little bit more about healthcare and how it impacts us locally. First, I'll say, let me maybe talk a little bit about Maine Health and what we look like. We have 9 acute care and critical care access hospitals. We have a behavioral health hospital here locally, a 100-bed hospital there. We do about $5 billion a year in revenues, which is a pretty substantial dollar amount. About 70% of those dollars actually come from governmental payers, which is so critical to the discussion that we're having today. When you think about it here locally, we have Maine Medical Center, 744-bed hospital, quaternary care, academic medical center, only level 1 trauma center in the state, only level 4 neonatal care and intensive care unit in the state. 400 residents that we provide education to. We do about $60 million in community and academic research. And then we do telehealth and on and on and on and on. And by far the largest hospital in the state, and providing care not only here locally, but so many of those transfers that come down from all the other hospitals. From a demographic standpoint, as you mentioned, you know, we hear from our CEO Andy Muller regularly the number of people turning 65 in this country is an astounding number, and it's going to only continue to increase. When you've already got the oldest state in the country, we certainly see that impact when you start to think about patients in the hospitals and how many of them need long-term care. We have 50 patients in our hospitals, in our hospital today that do not have a place to go because there is no long-term care facility for them to go to. And that has substantial impact that we can't accept all the transfers that we would like to be able to accept. Certainly from a pay standpoint, those patients are there. We don't get paid more money because they're in there for, sometimes it's an extra 10 days, 20 days, 100 days that we can't get those patients in. So the demographic situation that we have here in Maine is extraordinarily substantial to our organization.
Good morning. Thank you for having me. As Quincy said, I'm Marie Vino. I'm a Senior Vice President for Northern Light Health, but I am also the President of Northern Light Mercy Hospital here in Portland. And Mercy has been Portland's community hospital for over 100 years, founded by the Sisters of Mercy. So we provide a large primary care footprint across the region. Mercy also is growing some of its other programs. We provide cardiology, a large GI program, orthopedics, spine surgery. We have a substantial birthing center. So really the smaller hospital in Portland, but a very big impact on the community and the work that we do within it. So Northern Light Health is a health system based in Brewer. We have 9 hospitals from Presque Isle to Portland, and then from Greenville to Blue Hill. We have a flagship hospital in Bangor, which is Eastern Maine Medical Center. As comparative to Maine Health, we are about a $2 billion health system, so much smaller than Maine Health, but providing care in some of the more rural areas of the state. So this challenge that we talk about with the aging of the population, that is even more exacerbated in the rural areas, as a larger percentage of the population there is over 65 as well. So the aged population has a larger burden of chronic disease, so the demand on our services is more. And so we're finding the demand for primary care, the demand for inpatient beds, et cetera, is posing a challenge. And as Britt said, we don't get paid anymore. In fact, they're usually not our best payer. So it's very challenging. We also have services that are supportive services in our system, home care and hospice services, which we also provide statewide, and transport services, all of which are very vital to the care of patients and moving them in and out of hospitals that also have reimbursement challenges. So I would say it's just a challenging system all around right now.
Thank you both. I want to turn our attention to the policy landscape that is touching healthcare right now. And I have to imagine a large reason why there's such interest this morning in this topic is that it's really hard to read the news and not see something around healthcare. And a lot of the challenges that healthcare is facing right now is being driven by policy that's having really extreme ramifications on our ability to continue to provide the healthcare that our communities need. We're going to talk about some impacts of the One Big Beautiful Bill that I know everyone is aware of. In that bill, there was a loss of about $1 trillion to healthcare providers, and that is mainly to hospitals over the next 10 years. That is just an astounding number. Just think of that $1 trillion. I'd have a hard time writing that out. In the state of Maine, we've also recently had a bill introduced, I think last week, LD 2196, for those of you who follow legislation in Augusta. And this bill was developed by a state agency. Its purpose is to try to make healthcare more affordable, but it would really decimate Maine's hospitals. So we want to talk a little bit about the impact of these policies on healthcare, and I'm going to start in the middle with our CMOs. Chuck, I'll start with you, and just share a little bit about what these decisions mean, like on the ground, as we're trying to provide healthcare to our communities.
Thank you, Quincy, and thanks again to the Chamber for having us this morning. So I'll be blunt. I think this bill, 2196, would really gut our ability at Maine Health to deliver effective care to you, to our communities, to your families. Just to be clear, we're talking about, you heard Britt mention our dependency at Maine Health on government payers, about 70%. And when we start capping our ability to generate revenue, my mic is sort of coming in and out, but that'll dramatically affect our ability to provide care, the care that we really want to and that we need to. I think Maine Health would be forced to make some very drastic decisions. We'd have to curtail our workforce. I think best estimates would be something like a third of our workforce. And that's a workforce of 24,000 people might have to be let go. Because we're talking about an over $600 million a year hit to the Maine health system. So those numbers are really staggering and they're sobering. At a patient level, what would that look like? Well, we already see lots of deferred and postponed care in Maine. I'm still a practicing physician. Today's Thursday, a week ago, I saw a 40-year-old man who came in with what's called an incarcerated hernia, a little loop of intestine stuck through a hole in his abdominal wall. That's a surgical emergency. He'd elected to defer surgery because he was afraid about out-of-pocket costs and what that would mean. Decisions like that people are making as they wrestle sort of cost of care and being able to access care are only going to get worse, I think, if that bill were to pass.
Can I just ask what the bill does? Does it kind of artificially cap what you can charge for certain services?
Yeah, it does. It's not necessarily a charge, but it's in terms of reimbursement. And as part of that, it's 200% of Medicare rates is what you can receive from the private insurance companies. And we'll be the first to say in Maine Health, and I know also Northern Light feels the same way, that affordability is so critical in healthcare. And it has been very difficult, especially for the people that are providing, in this audience, that are providing health insurance for their employees. And so we know that we need to come to the table, and there needs to be a lot more discussion about how we can make healthcare more affordable. At the same time, when you set these caps, we're talking about hundreds of millions of dollars of potential loss in reimbursement. As Chuck said, then you're starting to talk about a third of a workforce of 24,000. You're starting to talk about a lot of programs, your trauma programs, your neonatal intensive care unit. Those are just some simple examples, but there are going to be some drastic cuts. And what that really means is then patients are going to have to go, and throughout the entire state of Maine, they're going to have to go and get their care outside the state. That's the last thing we want to do, is to have people have to leave our state to receive health care.
John, we'll go to you on just the impact this policy is going to have on healthcare.
What I would agree with both of what you've both said regarding this particular policy, but I'll focus on the big, beautiful bill, which also has oversized impacts. So the Maine Hospital Association has estimated between 2027 and 29 that about 37,000 people will roll off of MaineCare, which is the state's Medicaid program. Everyone in this room knows that CMS and Medicaid doesn't cover the cost of care, obviously, and the government knows this too. And I'll use this point to kind of educate everybody about how perverse and sort of nonsensical the healthcare system financing is. Well, if 37 people roll off of MaineCare, most of them will become unfunded, and the hospital systems will still provide them care, but will be doing it without reimbursement. We generally get maybe a nickel on the dollar for a patient that doesn't have insurance. So that sounds bad, but it actually gets much, much worse. And why is that? The government recognizes that Medicaid, MaineCare across the country doesn't cover the cost of care. So instead of increasing rates of those government payer patients, what they did was they created a program called 340B. And what 340B does is it takes money from a large profit center in the healthcare sector, which is pharmaceuticals, and then transfers it to the hospitals that are taking care of a large percentage of MaineCare or Medicaid patients. Now, in order to qualify for that, you have to see a large percent of MaineCare or Medicare patients. And so by rolling people off of MaineCare, not only do you lose that funding, and the funding basically goes to zero, your 340B privilege is also in jeopardy. And that 340B privilege is put there as a patch to help hospitals survive with the high percentage of government payers.
Thank you. Marie, anything you want to add?
I just wanted to speak to the concept of affordability and the fact that people are concerned about the cost of healthcare, and we are often, I would say, thought of as the drivers of those costs of healthcare. But, we've talked a lot about government payers not covering the cost of care. And since the pandemic, we have all been challenged with major inflation of costs for all of the things that we have to provide healthcare. So our labor costs are up, our pharmaceutical costs are up, our supply costs are up by about 17%. Our reimbursement increases have gone up about 7%. So there's already a 10% gap in what it costs us to provide the care versus what we're getting paid. And so all of these policies that they've just referred to, 2196 and the big beautiful bill, are looking to reduce that reimbursement even more while those inflationary costs stay there and the reimbursement continues to go down. The math just doesn't add up for us to be able to continue to provide services at the levels that we do today. And that's what we do, right? When we know the reimbursement is going down, we've talked about job losses, we look around our organizations and we say, what are we going to not be able to provide anymore to be able to fit within the cost structure that we're given, which means services close and access for patients gets worse. And that's really just the bottom line of the whole thing. And it's very frustrating for us, and it's very frustrating for our community and our patients, because at the end of the day, we're caregivers, and we want to provide care. And it makes it very difficult.
Well, let's stay on the topic of cost and coverage and talk a little bit about the employer pain points around healthcare. I know I get asked all the time, how much has your insurance gone up? How much are you covering for insurance? It is definitely a big topic of conversation amongst employers. It's such an important benefit that we provide employees, and also the cost is just going up dramatically year after year. So I'm gonna start with John and then Chuck. Can you both speak to how healthcare is evolving and how that evolution impacts the cost of care? And then what are the biggest drivers that are causing the cost of care to go up every single year? John, we'll start with you.
Sure. We talk a lot about how healthcare is evolving from inpatient to outpatient, but I want to focus on something slightly different because it's also very, very important, especially in Maine, and that's the workforce. And especially when it comes to the providers of care. Let's talk about the physicians, for example. People just aren't trained the way they used to be. It used to be you could have a generalist physician. Well, that person almost doesn't exist anymore. There's a handful of general surgeons around, but for the most part, they're hepatobiliary surgeons or they're colorectal surgeons. And why this gets important, and really one of the Achilles heels of the state for the provision of care, is there isn't that many people in it. There's not enough people to generate the pathology to support some of these specialists, especially when you get into the rural areas. So that makes it very difficult. It drives up the cost of care. Access goes down. Patients have to move. There's dissatisfaction. So that's one part about the workforce. The second one, and this is sort of fascinating, is a generational change. There's no more Dr. Huxtables around who are on call 24/7, 365 for their panel of women who are going to give birth, right? That person is a rare bird. And so now, as opposed to having one doctor that might cover a community, gosh, you need a team of maybe 4 or even 5 in order to cover call, because people aren't willing to drive in every night anymore. And that's a change in sort of the provider and the physician culture. And again, especially when you get out in the community in the rural areas, the scale of the human pathology just doesn't support that many people. So now, in order to have reasonable work-life balance for those folks, maybe you're bringing in a locums tenens doctor to give that doctor a weekend break or something like that, and it's all adding significant cost to the system.
Yeah, I agree with everything John and Marie have said about workforce. We certainly feel those realities at Maine Health. I think another major driver of cost is that just the very provision of care and what that care looks so different now in 2026 than it did even 5 years ago. So we're seeing the advent of precision medicine. For those of you who've never heard that term, Soon to be gone are the days where you might come see me, I diagnose you with high blood pressure and I give you a medicine because studies show that it works for 70% of folks. What I'll do first is a blood test and figure out what your gene profile looks like and which drugs are most likely to work right out of the gate. The same is true with your depression. That it is a monstrous step forward in our ability to provide great care right out of the gates, but it comes at a cost. So a very poignant example, we screen all newborns for a condition called spinal muscular atrophy. It's a fairly rare genetic condition, but we started screening for it a few years ago because there is now gene therapy that we can administer which can change the arc of a disease which is almost universally fatal in its most severe form or commits a child to a lifelong disability. If you treat the child early enough. So back in earlier this winter, we at Maine Medical Center became the first site in Maine to administer this gene therapy to a 4-week-old infant, which will forever change his life. That's the great news. That therapy cost $2.4 million in a single dose. So these are the painful realities of the costs of therapy that come with these extraordinary breakthroughs that we have. Obviously, we're not at Maine Health just pointing fingers at others and saying, the price is too high, so we need to pass that through. We have accountability and responsibility, and we're doing a lot to look at how can we be better stewards when there's 3 different drugs available to provide anesthetics in the operating room and there's a wide cost difference? Well, that's on us, and we need to do our due diligence to say, how do we provide the best care for the least expensive option and maximize value for patients and for payers and for employers? But I think that rise of precision medicine, which is great for all of us, also hurts.
Thank you for that. Now I'll turn to Britt and Marie to talk about hospital consolidation. So we've seen hospital consolidation across the country and in Maine, and I have to imagine we're going to see more just when you look at the dire straits some of our hospitals are in financially. Can you talk about what the impact of that is and how that's impacting our ability to deliver care? And I'll start with Britt.
Yeah, I think you said it very well that we've seen consolidation in the state of Maine, and we will continue to see consolidation. I think, and obviously right now, Maine Health is looking at the integration of York Hospital into our system and going through a process to make that a reality. I had our CON hearing this past week, and so we're hopeful that that happens in the next several months. I think probably the way I can describe it is it costs a lot of money if you are on your own as an organization and trying to make it as a hospital. And I'll use a hospital to start with, or you could say physician practice as well. And the reason I say it costs a lot of money is that you have to worry about how much does it cost to get a claim paid. You know, there are some statistics out there that it's between 8 and 12% of our cost are in order for us to not only be able to submit a claim to get paid, but then to follow up because there will be a denial. Medicare Advantage has about a 30% denial rate, in which then we know we will end up getting paid on the back end. That's considerable cost. An electronic health record is very difficult to maintain, and it's costly. We have a very large system known as Epic. And because of that, we're able to provide that as an example from a consolidation standpoint. If you're a physician practice, you know, scheduling and trying to get patients and trying to advance that, and you start to talk about artificial intelligence and so many other avenues in which the larger systems are able to advance probably a little quicker, a little faster, and at a dollar amount that is less than if you're trying to do that alone.
Thank you, Marie.
I'd like to give a real-world example of where consolidation can be a positive for hospitals. So I know everyone is probably aware, like Northern Light Health had to make the difficult decision last year to close a hospital, and we closed Inland Hospital in Waterville, which is a project that I worked on. But I also had the privilege to lead a hospital called Mayo Regional Hospital in Dover Foxcroft at a time when we were losing millions of dollars a year, and the board decided they needed to find a partner, and at the time it was Eastern Maine Healthcare System. So Mayo Hospital merged into the Northern Light Health System on March 1st, 2020. And I was their president at the time, and I can tell you that joining the health system was likely what saved the hospital, and that we probably would not have survived the pandemic on our own, and we were a very grateful organization to be joining a health system. So it can be, consolidation can be a positive, particularly for small rural hospitals, and there are many out there that are still standing alone that really wish they had a partner now. So it can help to have small hospitals join systems and benefit from some of the scale that they have and some of the services that they otherwise wouldn't be able to provide well on their own. So it can be a positive as well.
Thank you. Let's move to access and capacity. I know we all know that hospitals have been operating at these extreme capacity levels, and there's not enough beds. If anybody's been in an ED lately, they are packed. People are in the hallways. People are getting triaged like in the waiting room. And so I want to ask John and Chuck, I'll start with you two. Why is this happening? And what system challenges are contributing to this issue?
Go ahead.
How much time do we need?
Can't say I'm surprised by this question. So I think you've heard Britt and Marie speak to some of those pressures and some of the crowding as well that Quincy, you just referenced. So just to sort of level set, sometimes there's the perception that our emergency rooms are jam-packed because people are just accessing the emergency room more and more. That's a piece of it, but to be honest, that's a small piece of it. We're probably seeing year-over-year growth of emergency room utilization somewhere between 2% and 3%, really, over the last few years. But our boarding crisis and our emergency rooms look profoundly different now, really ever since the pandemic. So why is that? It's fundamentally a flow problem of patients through our system. If you are unfortunate enough to have to be admitted to either of our facilities, it is a minority of the time that you go home without needing any other care. Most patients will need something after they leave. Either home health care, a visiting nurse comes to check in on you and help care for you, maybe dress a wound. You may also need a stop at a skilled nursing facility or a rehabilitation hospital, or maybe you are now so sick and frail that you need long-term care. It's the dependency upon those additional services and what's happened to those services that has really, I think, crippled so many acute care hospitals. So just put some numbers on it. The state over the last decade has lost about 40% of its adult skilled nursing facility beds. It's even worse if you're a child and you need a residential facility. The state of Maine has lost almost 80% of those beds. So as a consequence, as Britt said, we have patients in our hospital who are medically ready to go, and yet they can't. There's nowhere where they can get safe care. I joined Maine Health about 11 months ago. Shortly after I arrived, Maine Health discharged an adult patient who had been at Maine Medical Center for over 3 years. 3 years. We routinely have children who are with us for months at a time. This summer had a child at our Biddeford Hospital who had been there for over 5 months, spent birthday, Christmas, all the major holidays there. So these are heartbreaking to all of us, but it really is a sort of a classic sort of throughput rather than an overutilization problem.
Yeah, it's interesting, your long stay patients. Based on our scale, we have a patient in right now that's going on 2 years, and last year had a pediatric patient in the ED for 3 months. So it is a problem. You know, it's interesting, like much of this, it comes down to money. And the cost to build hospital space is astronomical. So maybe it costs you $30 a foot or whatever to build out your office building. It's 10 times to 30 times that amount to build out a hospital. So the inpatient area is really precious space. Now, back in the day when money was flowing freely in healthcare, we built giant hospitals. Mercy State Street had 200 beds. Mercy Fort River has 80 beds. and it was sized precisely to match the volumes that we expected, plus about 20% to allow for growth when that building opened in 2021. And frankly, it works. Most of the time, it's a relatively small hospital that runs busy, and we do okay. But when there is a surge, and usually it's some sort of respiratory virus, this year it was influenza, last year it was COVID, and a bit of RSV, both hospitals are overrun, and there simply aren't enough inpatient beds in the community, and that causes backup and long ED waits, in addition to everything that Chuck mentioned. Now, I'll take the opportunity just to state, this is also the reason why a Mercy Hospital can exist, in addition to the original mission of the Sisters of Mercy, is that it is a community hospital which takes care of sort of 80% of what makes people sick, but we're not doing the gene therapy, we're not doing the transplants, the high-end, high-cost care that's happening at Maine Medical Center. And so because of that, we can do it at a lower cost point and actually make a small margin on community medicine that, I don't want to speak for Maine Med, but likely they're breaking even at best, right? They really need to have those tertiary patients, and we're very grateful to have them next door, and we're one of their biggest customers. If we have a patient, my own mother-in-law, for example, was in the Mercy intensive care unit, and when she needed the cardiac critical care unit, we moved her to Mercy. But for the patients that are sick with your community illness, then we can do that. We can do that very well at Mercy. But at the end of the day, it's a small hospital. That's all that we could afford, given the current states and the margins in healthcare to build. And when the population gets very sick with a surge such as a respiratory virus, the system gets overwhelmed.
Thank you. Britt and Marie, I'd like to talk about some of the broader economic impacts that all businesses face around housing, around workforce, around cost of living. I know it can be really hard to attract talent at times because of those issues that we have in Maine. We have a high cost of living. Housing is really difficult to find, and it is not inexpensive. And healthcare is not immune to those barriers. So I'd love for both of you to talk a little bit about what you're finding as the biggest barrier to attracting the workforce that you need. Want to go first? Mm-hmm.
I think the availability of the people is first. We have a small population in Maine, and attracting the workforce that we need and being able to be competitive with wages, et cetera, is the first thing. Maine has a projected nursing shortage of over 3,000 nurses by 2032, I think is the number. So there just aren't enough to go around, and that's for physicians, that's for nurses, and that's for, we have trouble finding medical assistants and PSRs, people to check you in when you go to the doctor's office. So having enough people to do the work is certainly one of the first biggest challenges that we face in the workforce. And we have strategies that I know both of us, do a lot to train our own workforce. We all have educational programs going on within our facilities to train CNAs and MAs and nurses, and of course, Maine Med trains a lot of doctors. But as much as we do, it's still not enough to fill the gap of what we need for workforce. And then, of course, you stated, and I'll let Britt address, and I know he has a passion to talk about housing, so I'll let him talk about that. But housing and other costs of living are certainly impactful to our workforce as well.
Yeah, I guess I'll start with affordability. I was thinking last night, if I'm with the business owners and the business community here, if I'm coming into a community as a potential employee of an organization, there are probably three things that I'm going to look at. And obviously I'm going to look for healthcare because that's my world and that's what I've been doing for 35 years. But then I would probably think about schools and then affordability. And affordability touches on so many different things, but the housing is one really critical thing, and that is such a huge factor when it comes to our employees who are coming in. I've had many people say to me in an interview saying, I really love this place. I would really like to come here. I like Portland, but unfortunately, I don't know if I can afford to live here. And then they opt to go somewhere else. So no doubt housing affordability is something that's really critical. You know, and then what that does, unfortunately, in the world of healthcare is that means that we have fewer people, and I'll use nurses as an example. We have several hundred contracted nurses still in our organization. That is to the tune of a couple $100 million, which is probably in a best case scenario 2 to 3 times as much as we would be paying for an employed nurse. But yet we, and I think we all feel this way, and I know that Mercy and Northern Light feels this way, as nonprofit organizations, we have to keep our beds open. We feel very strongly, especially as a tertiary quaternary care organization, you know, sitting a half mile up the road here. So because of that, then we still bring in these contracted labor nurses, and we pay for that, and that takes away from other things that we can be doing. And yes, and we know that from an affordability standpoint, those costs are going to be eventually going to get to the people who are, you know, are certainly paying for the cost of health care. And that can be via Maine Care, that can be via Medicare, that can be private insurance. And that's the last thing we want to do, but unfortunately that is the state that we're in.
Thank you. And I know we can't escape a day in the world of the chamber without talking about housing. So I appreciate you bringing that up. And even for people who are comfortably housed, this is an interesting way to connect the dots as to how lack of housing can impact you in the realm of healthcare. If we're not able to attract the workers that we need, we're not able to provide the level of healthcare that we all expect. So again, beating the drum on more housing. I know there's some counselors in here and elected officials here. That is still our priority, and we're trying to make some good strides in bringing more housing to market. A question for all of you. I want to talk a little bit about collaboration amongst your systems. Like, we've got 2 amazing hospitals that are about a half a mile apart from each other on the peninsula in Portland. And can you talk a little bit about how you collaborate, what that looks like, and what the benefits are of that collaboration to everyone in the room? And I'll start with whoever wants to start, or I'll pick somebody.
Sure, yeah. Well, you know, Chuck and I have the easy job, which is the clinical collaboration. And I would say the relationship between Mercy and Maine Medical Center is the best I've seen in my 25 years, 5 of which were at Maine Medical Center and 20 of which have now been at Mercy. The docs, the nurses, the pharmacists, blood bank, they're communicating constantly about various needs. And not only do we move drugs and blood and things of that nature back and forth between the hospitals, but patients move as well. Usually they're going from Mercy to Maine Med to receive some higher level of care, but sometimes they come the other way. They come the other way as well. And then when it comes to serving the community, the relationship is also good. And I'll give you one sort of concrete example. Chuck was talking about emergency departments being really backed up earlier. And a couple of years ago, this problem was really at a high level, to the point where the emergency departments were going on diversion. And when you go on diversion, basically you call the ambulance companies and say, don't bring us any more patients. Now, for Maine Medical Center, that meant don't bring us any more. You can still bring us trauma patients, you know, very sick children, things that they specialize in. But for the average ambulance, you know, our doors are closed. Mercy the same way, Southern Maine Medical Center the same way. And what this was resulting in is patients that wanted to go to Maine Med would come to Mercy, and now they're admitted at Northern Light. Patients that wanted to come to Mercy would go to Maine Med, because one goes on diversion, the other one gets busy, then the other one goes on diversion, now the other one comes off diversion. And it was really a shell game that didn't make any sense to anybody. And so we brought a group together of all the chief medical officers and chief nursing officers of the local area, sort of southern Maine hospitals, and went through a process to eliminate diversion. And we haven't had any emergency department diversion in over 18 months. And so that was a nice success.
John, I love those examples. I would also say that one of the strongest ways we can show collaboration is that we complement each other and we're not redundant in the ways in which we support Portland and the community. So as nonprofit hospitals, we regularly do community needs assessments. That's something that is sort of required by payers, and so we try to get a really close read of what is it that the community needs and how could we best need it, and then making sure that we're addressing those needs in ways that sort of make sense together. So for example, a real critical need is around how do we provide care for new mothers who are transiently or unhoused, where the housing stability changes once you introduce a newborn into the mix. And just a call out to Mercy, their partnership with Francis Ward, creating that opportunity for where a new mother with an infant could reside and receive peripartum care. On our side, we know that food insecurity is a major issue for our community, and so we're thrilled with our partnership with the Maine Medical Center Food Pantry right down in St. John that provides some assistance for food to the tune of 800 clients per week. It's actually been going up as of late. And so I think that's just sort of another example where we're trying to work together in support of our shared community.
Could I just add a little bit about the community health needs assessment process? And that is a statewide planning process that has been a partnership of Northern Light Health, Maine Health, and the Maine CDC and other health systems for many years now. I would want to say it's almost 20. And so the results that we get from those community health needs assessments really drive us to show, what does the community need? Usually the top 4 things that come about are chronic disease, depression, substance use disorder, things of that nature, are very similar across the state. But we all take that data and that information, and as Chuck, thank you for the shout out to Francis Ward, we do provide that care. Another program that Mercy has in the community is our Macaulay residences for women with substance use disorder. And we've had great success in breaking that cycle of substance use disorder in young women and in families, and to the extent that we're now expanding it across the state to 4 more locations in rural areas. So we have 4 and we're adding 4 more. So that's just an example of what community health needs assessments do to help you drive the work that you do outside of the hospital walls, and we all do that. And I know you have some other examples to share as well, Brett.
Well, yeah, I was thinking working together as part of our slogan here today, and that is the community is so critical. And we can't do it without community. I think a great example, I saw Mayor Dion earlier, is we've got a great collaboration with the city in which a mobile van and a mobile medical van was bought for us. It's a substantial dollar amount, you could imagine that. And we're able to go and meet the unhoused where they are, and not having them come to us, and those patients come to us. And so I think that's really a great example where we have to, again, it's a collaboration not only with the hospitals or the health systems or physician practices, but also with the community. I think about the Preble Street Collaborative as an example as well. And there are so many more examples that I could list, but I think that's really critical, is that the community component, and it's one of our strategic initiatives, is community, and it's because it's so we can't do this alone, and I don't think any of us would ever even dream to try to do that alone.
Thank you. I've got 2 final questions for the panel, and then we will open it up to Q&A, and we'll try to do these relatively quickly. But the first question is, clearly there are a lot of challenges facing the healthcare world right now. So what gives you each hope for the future of healthcare in Maine? And I hope you have an answer to that question. And Marie, maybe I'll start with you and we'll just come down this way.
Thank you.
Okay, well, I say I have a lot of hope because coming here to Mercy, even though we have our challenges, we have our headwinds, we are in just a great environment, and there's a lot of really positive things happening in healthcare. Technology is advancing, and here there is good access and there is high quality care, and it's exciting to talk about growth and starting and providing new access and new services to patients. So that's very different than how it feels to be in the more rural environments in Maine. So I say I have a lot of hope for what healthcare will look like in this region in the future.
Well, look, people love to be in Maine, right? That's why people that live here, and many of the people that recruit come here. And while we're primarily 90% of this has been about the economics and the business aspects of healthcare, our day jobs is focused on quality, access, the provision of care to people, making sure people are getting the right care in the right place. And the people doing those jobs, they're passionate about it and they really love to do it. So it's kind of really up to us and the business community and the healthcare leaders to ensure that there's a funding mechanism there to ensure that they can continue to do that. But it's the people, it's the work, it's the calling aspect of it, the nobleness of it. That hasn't changed from the start of the Sisters of Mercy when they began their mission to provide health care 100+ years ago.
I like the passion and the nobleness. I'll sort of riff on that. I spent about 2 decades of my career in a very congested healthcare market where you'd wake up in the morning and the first thing you thought about was how to wrest some market share from a competitor across the street. Here, I wake up in the morning worried that my friend John may call me about some challenges that he's facing. It's a profoundly different mindset. And it's a commitment from everyone who works in healthcare in the state to advance and secure and support the care for the residents of the state. And I can't, as somebody who is a new Mainer and has come from away, it's been made very clear to me, it is astonishing how palpable that sense of commitment to mission is. And so for me, that's what I find truly inspiring about having the privilege to work here.
The first thing I would say is recruit in the summertime, not necessarily in January or February. Okay, that's one thing I've learned in my 2 years here. So number one rule. But I would say a couple things. I would say every state in the country will say we provide great quality of care and great safe care. And the difference in Maine is, and this is from a guy who loves statistics, the data actually demonstrates that we do it better than almost anywhere in the country. That makes me very comfortable every day walking into where I work, knowing that we are providing great quality of care, great safe care, the patient experience is off the charts good, and that makes me feel really good, and it makes me want to come to work every day. So, and that's as a person that's only been here for 2 years, but that's real, and the numbers don't lie in this case.
We talked about workforce here and recruiting people to Maine, and we talk about workforce every day at the Chamber with our members and how important that is. And I've always said that 2 of the best assets we have in Greater Portland are Northern Light Mercy and Maine Medical Center. And that is really part of our recruiting to get people here, to know that you can live within 20, 30, 40 minutes of 2 of the best medical institutions in the country. So I just want to thank you all for being here. Thank you for what you do every single day to provide the necessary health care to our community. And with that, I would love to open it up to questions from the audience. It's got to be something. Oh, I see some hands in the back.
Your name, your organization.
Okay.
Quincy, thank you. You're doing a wonderful job up there. It's a tough subject. I'm Anna Klein Christie from Baxter Academy, which is a public high school up the street. And so my question for you is around workforce development and aspiration in younger people. We have kids who come and intern at Maine Med, but I would love to hear from you a little bit about your thoughts around aspiration for kids in medicine here in Maine and how we can engage kids more.
I'd love to be able to take that because there's something that I'm going to be getting involved in the very near future with the boys. I'm a board member of the Boys and Girls Club of Southern Maine, and that is a great opportunity in which we have so many kids who don't know what they want to do and give them the opportunity to explore. And an example of that, and I've seen this in the past, is you spend 1 month and you get a chance to go visit radiology and understand what a radiology technologist does, because no one knows what a radiology technologist does. And then you got a laboratory tech. You know what the nurses, you got physicians, you got you got therapists, you have pharmacists, and give them the exposure at an early age, because trying to get them to shift at the age of 20 or 21 is too late. You got to start when they're 13, 14 years old in order to expose them. And we've got a great opportunity within our community here, and that's just one example, the Boys and Girls Club, but that's where we have a couple hundred kids every single day that you kind of have an audience sitting right there as an example. So I do think that's a great opportunity, and I appreciate the question, because I think historically we've waited too long and too late to try to convince kids to go into science and go into healthcare.
Great question. Any additional questions?
Hi, my name is Gwen Ellen O'Donnell. Thank you so much for this panel. It's fascinating. My question is, I'm really curious to know about the collaboration and coordination between Northern Light and Maine Healthcare in terms of providing critical services such as OBGYN services and other things that are disappearing from, other specialties that are disappearing from rural Maine. Thank you.
I would say that we are all concerned about some of those services that have disappeared from other rural areas, particularly OBGYN services. We both of our systems, and I speak a little bit about Northern Light Health in the Bangor market, are preparing and prepared to care for those patients that are going to come to us and need that care. So we are, building up our physician workforce and making sure that we have the nursery levels that we need to be able to take care of those kids. Here in Portland at Mercy, we only have a level 2 nursery at Mercy, so which is a higher level of care, but there are many days that we collaborate with Maine Med, and some, those babies have to go to their NICU to be cared for, and so it's a very tight relationship, and it's a phone call. And they're taken care of very quickly and very expeditiously. So it's a very strong collaboration. But we are both, our system is building up to be able to be the safety net for those patients that are losing care in some of the more rural areas of the state.
Yeah, I think I fully agree, Marie. We are doing the same, and I think the reality is that there are just a limited number of providers that we can recruit and bring to those areas where there's now care deserts that are emerging across the state. So we have to lean into some technology solutions, at least that can partially address it. So I'm really proud of what our neonatology team, and we actually, Mercy and Maine Medical Center have a shared neonatology team across our 2 neonatal intensive care units. But that team in particular has dramatically stepped up its ability to provide virtual and remote neonatology support. So what does that even mean? So you could be at a hospital that is not a level 2 or level 4 neonatal intensive care unit, deliver a ill baby, and really with the touch of a button, there's a neonatologist on a display over the isolette, walking the care team through the resuscitation of that critically sick child. The technology is sort of awesome to behold, but we have to lean into those solutions. If we can't bring providers to where patients are, then we have to figure out a way to do that more creatively.
Thank you. I think we have time for one more, and then I have a little lightning round question.
Thanks so much. I'm Anna Bullitt. I'm the chair of the Health and Human Services Committee for the Portland City Council, and in my day job, I'm the senior director of health and nutrition at the Opportunity Alliance, which is the CAP agency for Cumberland County. First, gratitude for all of you. I often say that, especially your frontline staff, your doctors, your nurses, your MAs are just fixing policy failures every single day, you know, and your social determinants of health screening process at Maine Health is really showing that. The other thing I'll say is that I've been astounded how fast you've all been able to pivot over the past 10 years to the constant emergencies. I know I've changed my operations at the Opportunity Alliance. I'm responsible for the WIC program, so now I like stockpile formula because I have PTSD from the formula crisis. So I guess my question is, from an operational standpoint, how have you changed your operations so that you're ready to pivot? I'm convinced the next thing is going to be a measles outbreak. Maybe it is, maybe it isn't, I don't know, but how are you planning ahead like that and being ready to respond in the way that our community is going to need? Thank you.
Well, there's crises that come out of nowhere, obviously, and requires an emergent response. But a lot of this are sort of, you know, avoidable crises, if you will. We all know the financial pressures that are coming to healthcare, and we're making changes now to try and become even more lean and more efficient. We know that there's going to be further deserts coming to Maine. We know that we're going to see reduced access just because of the finances. And getting back to the point that I made earlier, the fact that we have this beautiful state to ourselves is both a blessing and a curse. The amount of humans out there to generate the business to support healthcare in rural Maine just isn't there. It just doesn't support the given current healthcare infrastructure. We know that, and we're making plans to be able to react to what we feel is coming.
I'll add that I think that the pandemic was sadly a great experience for us to sort of do get a lot of experience very quickly on sort of how to deliver care in a very constrained way. And those playbooks, for better or for worse, we've dusted off a lot. So just in December and January, we saw the worst influenza A spike I've seen in my 25 years. It didn't approach March of 2020 with COVID, but it came close, and we were worried. So we could actually quickly pivot to sort of say, what does care look like if we have to render it in areas where we don't usually provide patient care? How do we think about supply chain differently so we don't get sort of caught out without PPE and masks? So I think that a lot of those lessons learned over the last 6 years, we're still leaning upon.
I would also add to what Chuck said, agree, but I think a lot of the lessons from the pandemic have now been built into our daily lives. Yeah. And so we talk about, what drugs are in shortage this week? What the storm is coming. Do we think it's going to impact our supplies being delivered? Where's the infection preventionist, and what are we doing about masking this week? I mean, that's part of our core day-to-day now. It's built into our operations. So it's not that we'll be reacting from a better position on the field, so to speak, than we were when we were surprised. So I think it's part of the day-to-day.
Completely agree.
Yeah, I would just add one other maybe focus, and that is our how to be proactive with the policymakers. And and one of the things that we've started to do is we whether it be breakfast with them or and I think a lot of the hospitals do that, and different legislators, and just having those opportunities to talk about long-term care, behavioral health. How can we work with the state better and in order to be able to, start to, I'm not going to say we're going to solve it because we won't, but to maybe get to a better place. And I think that's really critical from a proactive standpoint. I think the issue around LD 2196, as we mentioned earlier, that is a drastic change. And that's one that we've never seen in the state of Maine. So that's the crisis that we're still, and obviously the Maine Hospital Association is helping us with that. But that is really critical. And if I could just say one thing to the people in the audience today is we need your help. We're talking about there would be massive changes to how we provide health care at Maine Health. And I'm quite confident many other health systems in the state. And we need your help to be talking about these things, because having healthcare that looks different than it does today is not good for anyone in the state. We realize we need to think about affordability, and we're trying to do some of those things at Maine Health. And we need to sit down with the state and try to think through that. but I'm not sure that this is a good example where there's a bill there that could be fairly draconian to our organization and to healthcare in general in the state of Maine.
Well, that was going to be my final question is, thank you. We're with the business community, so how can the business community help as we try to solve for these healthcare challenges in the future? Britt clearly said we need help with policy, we need to talk to our lawmakers, we need to understand how these proposed legislation is going to impact how you receive care and your access to care. I'll just go down the line too. Chuck, if there's anything you want to add to that.
I mean, you know, getting out of this is not just one stakeholder pointing at another and saying it's your problem. It's all of our problems. And I hope you get the sense here. I think certainly representing healthcare in Portland, we are a major stakeholder. We are acknowledging where we've got room to give and to learn and do better. We want to link arms with all of you and really work together to help our policymakers understand what's common sense healthcare reform policy that doesn't hurt our residents, but it helps them.
Yeah, I can't believe we've gotten this far in the conversation without the words cost shifting coming up, to be honest. Because if you want your employer-based insurance costs to go down, government payers the government rates have to come up, and it's really as simple as that. You know, the way this system was set up decades and decades ago, where the government pays this and the private insurance pays this, doesn't make any sense. And so, you know, this needs to come up, so this needs to come down. And I would ask you to advocate for that in your ways.
Yeah, I think I would just add, I agree with everything that's been said, and just, you know, try to understand, try to learn about how healthcare works, and reach out to all of us, and we'll help to educate you on, you know, how it works, because I've found when I have been with legislators on commissions that I've served on that, you know, even they don't really understand the dynamics of how healthcare works and how it's funded, and so we really need to educate people, and we want you to work with us on that. So that would be my final ad.
This has been such an interesting conversation. I feel like we could have taken any one question and just spent the entire hour on it. So I know we covered a lot. We are going to make sure we keep all of you updated on the issues that we're following in terms of policy that's going to impact how we are able to provide healthcare in Maine. And I just want to thank the panel. Thank you for your time and bringing your talents to the stage this morning. And thank you for what you do every single day to serve our community. It's incredible. It does not go unnoticed. It's needed, and we're just very grateful to have you in our community. Can we have a round of applause for our panel?